What we really need to do is ramp up the campaign very quickly. And an important part of that is getting out in the communities and talking to seniors and talking to the community groups in our areas. And a lot of that is the work that the activists and chapters are going to be doing. So what I have for you tonight is talking about direct contracting 101. And this is really just an overview, give you some ideas for when you go out and speak, specifically to senior groups. And before we get into the content and the messaging, I just wanted to step back and say, why are we talking about seniors right now when before now we've been very much focused on messaging for members of Congress, messaging for journalists. We think it's worked fairly well. Why are we going directly to seniors now? I mean, obviously, seniors are the ones who are most affected by this program. They're natural allies. That's fairly obvious. But we also need to remember that direct contracting will radically transform Medicare. And we need to be clear about this. This isn't just something that's affecting seniors today. This is something that's going to change Medicare forever. So not just seniors, but anyone who's going to be a senior at some point in their life should be concerned. But the reason we really want to reach out to seniors in our community is because we're not going to win this fight without having an army of seniors on our side, because seniors vote, they call their members of Congress. There's nothing a member of Congress fears more than an army of pissed off seniors banging down their door. So that's what we're going to do. So when you're speaking to groups in your community, you may have an hour, you may have 30 minutes, you may have 2 minutes. But no matter how much time you have, there's 3 key ingredients I want you to have in your presentation. I want you to educate, advocate, and activate. And I'll briefly explain what I mean by those 3 things. So educate is probably the most important because this is something that almost no one has heard of, especially until now. So it's going to take a lot of time. And if you have the time, try to spend it on the education part, explain in very simple and concise terms what direct contracting is. That's probably your biggest challenge right now. And then you can move on to advocating, which is a little bit more fun. Explain why this program is bad news for both seniors and Medicare, and try to unpack some of that, like we were saying, some of this jargon around value-based care and saving money and coordinating care. Let's kind of cut through that and talk about what's really going on. And then finally, you want to activate. I think especially now, our potential advocates may feel like they can't really make a difference. So it's your job to challenge them, get them excited, and give them the tools to get involved, give them something to do, give them concrete action steps where they can get involved. And we'll have more of that at the end. So that's kind of the overview of how we should generally talk. Now, this is more getting into the messaging when we're talking to senior groups. So just what's our basic understanding of what direct contracting is? So it's a program that was launched late in the Trump administration that would change the way that Medicare pays for seniors' care in traditional Medicare. So instead of paying doctors and hospitals directly, Medicare gives these third-party entities called direct contracting entities, or DCEs, a payment to manage seniors' care, and manages in quotation marks, and allowing them to keep as overhead and profit what they don't spend on medical services. So here's a simple way to look at it. Traditional Medicare, it's very straightforward. Medicare pays your provider directly for the care that they provide. Under direct contracting, Medicare now pays a middleman called the direct contracting entity to, quote, manage your care. They're the third party between Medicare and your provider, and to a certain extent between the patient and provider, but we'll get more into that. One thing that's very unusual about this is that it's a big change, but it's completely under the radar. And this would be a good time, if you are giving a presentation, ask your audience, who here has heard of it? Now that I've explained it a little bit, who here has actually heard of direct contracting? Everyone's going to raise their hand and say they've never heard of it before, which begs the question, how is this happening without any of us knowing about it? So if you have time, it's a good opportunity to talk about the structure of, who controls these agencies and how this came to be without congressional oversight. So let's dig a little bit into who's in charge. So so this is the organizational chart for Health and Human Services, which is the agency that's responsible for most of our nation's healthcare system, to the extent that we have a healthcare system. And the head of that agency is Secretary Javier Becerra, who is appointed by President Biden. So he is the person who's really ultimately responsible for making the decisions about what happens, within this flow chart. And that's why our petitions are geared towards him. Now, who's actually responsible for Medicare itself? It's the Center for Medicare and Medicaid Services, which is CMS. For some reason, they dropped the second M in there. They're the ones that manage Medicare. But if you look at how CMS is organized, this is the flow chart for CMS. If you look really squint your eyes and look really closely, you see there's this tiny little agency within CMS called Center for Medicare and Medicaid Innovation. And they are the agency that came up with direct contracting, and they've been empowered to come up with these pilot programs and expand them to all of Medicare or Medicaid without congressional approval. And this is really key, and it's worth repeating in your presentation. They do not need congressional approval to do these pilot programs or expand them to all of Medicare. So, and I'm glad that I think it was Andy who brought this up, our friend Adam Baylor, I think that's who you're thinking of. So when direct contracting was first developed in 2019 during the Trump administration, Adam Baylor was the head of CMMI, the Center for Innovation, and he was the former roommate of President Trump's son-in-law, Jared Kushner. And so he was in charge of CMMI. They started direct contracting. Now, the fun thing is that before he ran CMMI, Baylor ran a startup called Landmark Health. Now, Landmark Health then became one of the first DCEs to contract with Medicare for the direct contracting program. So clearly, as soon as this program started out, there were already conflicts, and it was, already kind of a suspicious program. So now that we've sort of peeked under the hood at the agencies that are responsible for this program and for its very controversial start, let's look more closely at the DCEs themselves and the people behind them. So first, we should say that it's still a very young program. It only started in April of last year, but it's already DCEs are already operating in 38 states and DC and Puerto Rico. So they're nearly everywhere right now, even though this is considered a pilot program. Now, virtually any type of company can be a DCE, and they don't have to have healthcare experience at all. They basically just have to have the startup money to get going. And again, applicants are approved without input from Congress, as is the case with all these decisions coming out of CMMI. And I'm going to pick on one DCE. This one is called Ilumed, and for some reason they don't like to capitalize the I in their name. Okay. So if you look at, this is from their website, this is their leadership team, and you'll notice that only one member of their leadership team has any experience as a healthcare provider. The woman I circled in red is a nurse. And not that we would be okay with this model if there were more providers in the leadership, but just to show you what this is really about. Now, the news page on the Ilumed website actually tells us even more about how their business works. There's the two top articles on their news page. The first is they just recruited a chief medical officer. So this is a year into running this program, and they just now have a chief medical officer. And interestingly, they recruited him from Humana, which is a commercial insurance giant that's very involved in Medicare Advantage, and that's where he actually previously worked. So that gives you a clue of what kind of model they're looking for. But I think more importantly is the second article about raising $16.5 million from Wall Street investors. That's a lot of money for a company that's relatively small within this space. So this is the question then, why are Wall Street investors so interested in a company that claims it's going to save money for Medicare and improve care? So again, back to this chart of how the money is flowing. We started with Medicare. Now Medicare's paying direct contractors who are paying providers. But what we don't see are the Wall Street investors who are paying these DCEs. So this is who the DCEs are ultimately responsible to. And they've got to make the case that they can somehow make lots of money and make their investors happy. Now, these investors are not dumb. They know that the money is going to be coming back into their pockets. So what's the plan? You know, how are they planning to keep these investors happy? So what's the question? How do direct contracting entities actually make money? Well, it comes down to two things. One, they need to maximize the revenue that they get from Medicare. That's the money coming in. And second, they need to minimize the revenue spent on patient care. So minimize the money that's going back out. That's how they're going to make that 16 million back. So first, let's look at the money that's coming in. And this is very important. And I'm going to get a little wonky, but I think if you have time to explain this, it's worth explaining because this is really key to their business model. So the first way that they make the money come in, they engage in a thing called upcoding. And if you know about Medicare Advantage, you probably know what that means, but you basically make seniors look sicker than they are because DCEs get a monthly payment from Medicare that's based on the diagnostic codes, how sick the patients look, not how much they're paying for healthcare, but how sick they look. So let's break down what upcoding looks like. And I blatantly stole this from one of Ed Weisbart's presentations. But a typical coding of a 76-year-old female, you know, you see obesity, diabetes, asthma, pretty typical diagnoses. Each one of these comes with what's called a risk score. If you add up the scores and then do some, there's a formula. Medicare pays each DCE, would pay the DCE $9,000 a year for this level of risk scores. Now, if you take that same patient and do some upcoding, you see that they took obesity and made it morbid obesity. They took asthma and made it COPD. The ulcer is now stage 3 and so on. You see in red where the upcoding happens. So usually it's the same diagnosis, just more, more extreme or a different diagnosis. So the risk score is 3.63. And now the annual payment from Medicare to the DCE is $32,000. So more than 3 times the amount if they did not do upcoding. And it's important to emphasize that this has nothing to do with the healthcare that they are providing to the patient. It's just what's in their records. So that's how the money comes in. And as you can see, there's a huge opportunity to just keep bumping those scores year by year. So we've established that DCEs, they're essentially using seniors to get higher payments from Medicare, regardless of the care that they're providing. But on the other end, how do they keep the money from flowing back out? How do they keep from having to pay for the actual care that they're supposed to be giving? And as we mentioned, because they are allowed to keep as profit and overhead what they don't spend on medical services, they now have this very dangerous incentive to ration and restrict care. And the program is young enough that we don't have the data on what that looks like yet, but we know that that is an incentive that is, it's guaranteed that this is going to happen because that's the incentive. And importantly, these financial incentives do not exist in traditional Medicare. Medicare is fee for service. You pay for the health services, and that's it. So this is a radical change to traditional Medicare. So now in the next part of the presentation, or of your presentation, again, this is sort of a template, we're going to talk about advocating. So we're going to talk a little bit, we went through the nuts and bolts of how this works. Let's talk about the kind of bigger picture reasons of why we need to stop the program. And the 2 reasons. The first is direct contracting threatens Medicare's solvency. The second reason is that it threatens seniors' health care and healthcare choices. So first, what do we mean by solvency? And that's basically, it's a fancy way of saying that this program could bankrupt Medicare. And that's what we're going to be talking about in our Senate hearing next week. So we all know traditional Medicare spends 98% of its budget on patient care, only 2% overhead. In contrast, direct contracting, the entities only spend an estimated 60% of what Medicare pays them So remember that $32,000 that Medicare is paying, they only have to spend 60% of that on patient care and can keep the rest as overhead and profit. And just to give some context, like a visual context, you see Medicare 98%. That's very efficient, great ratio. And even Medicare Advantage, they're still taking 15% in their pockets, but they're required to spend 85% on patient care. Now, DCEs, they don't even have that 85% requirement that Medicare Advantage has. And this is an article from Health Affairs in the fall that calculated that basically they only have to spend about 60% on patient care, and they can keep the rest. So this should be shocking to anyone that this amount of waste of our taxpayer dollars are going straight into their pocket and not into seniors care. So the other reason that we need to stop direct contracting is that, we've talked about the dangerous incentives for DCEs to restrict and ration care. We know that, but on a deeper level, it undermines seniors' choices. So under this program, up to 30 million seniors who actively chose traditional Medicare because they value having the free choice of provider may be automatically aligned with the DCE without their full knowledge and consent. And aligned is the CMS's way of saying assigned or enrolled, but we'll use their language, aligned. So how does that happen? So CMS will search 2 years of each senior's claims history to see if the senior has gotten care from a DCE aligned primary care provider. And then they will automatically enroll the senior with that DCE. And the senior will get a letter, maybe, that looks something like this. This is a letter that someone sent us, that it's informing them that they're now part of this DCE. And of course it says no action needed. And if you're like me and you get a letter that says no action needed, it's probably going to go straight into the recycling. You're not going to pay that much attention to it. And it's a lot of gobbledygook, but most seniors aren't going to understand what this means. So if you're a senior and you find that you get this letter and you're now, because of your primary care provider, aligned with the DCE and you don't want to be, the only way to opt out of the DCE is to change primary care physicians. And we should make this definitely a part of every presentation. You have to change your doctor if you don't want to be in the DCE. And that's a big ask for anyone. But if you imagine being in a rural area or underserved area, it could be nearly impossible. So logistically, that's a challenge, but it's also undermining traditional Medicare's promise of free choice of provider. This is why majority of seniors choose traditional Medicare, because they want that choice, and you're undermining that choice and undermining that promise. And the other reason is, even if you're not a senior right now, you're not on traditional Medicare, as I think it was Ollie had mentioned, CMMI has said in the last few months that their intention is to move all fee-for-service, that means traditional Medicare beneficiaries, into one of these, value-based, however you want to say it, into one of these plans by 2030, or maybe even sooner. So this is a radical change to Medicare, and it's happening very, very quickly. And it's going to completely change Medicare. The Medicare as we know it just simply won't exist if we let this continue. So we need to get in this fight. And finally, in the advocate category is where's Congress in all this? And you can see our folks standing in front of Congress. Why isn't Congress trying to stop this? Why aren't they involved? Well, until recently, most members of Congress had never even heard of direct contracting. And that's for good reason, because this was a program that was designed to fly under the radar. So the good news is that we've been working really hard, including everyone in this picture and everyone on this call has been working really hard to talk to our members of Congress, to talk to reporters, write letters. And just a couple of weeks ago, 54 members of Congress wrote a letter to HHS demanding an end to the program. So the awareness is definitely rising. Bad news, as Susan mentioned, is now the DCE owners and investors are fighting back because they know that we're coming after them. We're no longer under the radar, we're above the radar, and it's making them crazy. So we're entering the next phase of this fight, and we need everybody to get involved. So this is where we get to the activate. So now we've got people, people are riled up. They feel like there's a chance to actually stop this thing. We think we can win. What can we ask people to do? This is something that's definitely should be part of every presentation. So if you're just talking to a group of individuals, the best way to get involved is to sign and share our petition. And note that if you do sign up for the petition, you'll join the mailing list. So they'll stay up to date on everything that's going on. So as the campaign evolves, they will still be in the loop on what's going on. And they could also write a letter to their local news outlet. And we've got tips for that on our website. And as Susan mentioned, that seems to really be getting under the skin of our opponents in the DCE industry. And then if you're talking to an organization, the one thing we want them to do right now is sign on to, we have a sign-on letter for organizations against direct contracting. We want to get as many local and national groups to sign on. They don't have to be Medicare for All supporters. We want everyone who's concerned about this to sign on. And we can put the link in the chat for that letter. And also they could share the petition with their members and other community groups. The petition is probably the single easiest and best way to spread the word about this. And that's it for me. I will, I can put a link in the chat of a template of this slideshow. I mean, without the beginning part of me talking about what you should have, you know, the activate, the educate, activate, with just the content, I could put that in there so you can download that and play around with it and decide what you want to use. And as I mentioned, we're going to have a training on the 16th, a standalone speakers training on the 16th, where we'll talk in more detail about messaging and also have a chance to really be more interactive and maybe practice some, what are the common questions that we get from audience members and how we can respond to that, so that everyone will be equipped to speak to community groups, maybe even to reporters, to anyone or members of Congress, to anyone that they want to talk to. But really, our main goal right now is to expand this to seniors